Just to reinforce importance of screening for men and mental tumors and these patients of net tumors, especially pancreatic nets.
Yeah, got it. Yeah, progressing further, I think CT and MRI are the first line of choice of investigations in these tumors. I think the gold standard investigation is, as we all know, is acute site scanning, taking use of the somatostatin receptors these tumors express. And they're quite valuable in terms of detecting diagnosis and also assessing the tumor burden, response to the treatment, and other things. I think more recently we are using PET scan, especially for poorly differentiated tumors with FDG, grade 3 neuroendocrine carcinomas more specifically. But I think gallium isotopes, 65 isotopes have been more used for nuclear imaging nowadays. I think they are almost replacing the occulted scanning, mainly because they are more easily accessible, and they are the generators which they use are more easily used, and the time required for the scanning is less when compared to occulted scans, and they have got more resolution. And also they can actually quantify the tumor burden and also help in response in the treatment. So in the coming days, I think we probably just looking at Total-Tate or Total-Knox scans rather than occult scintigraphy. And other evaluations like cardiac MRI, EU endoscopic ultrasound and other methods. There are a lot of investigations which can be used depending on the presentation. I think just a brief note on surgical management, it just remains main standard in spite of a lot of advances recently. I think surgical should be offered in all the patients who have localized nets, who also have limited disease, and also especially recurrent or metastatic tumors. Locally advanced tumors should be performed to achieve negative margins and adjacent en bloc resection of adjacent organs. And liver resection and liver tumors, they've got a lot of options now, ablative therapies, TACE and embolization. So just a brief note on bronchopulmonary nets, because they are actually the second most common nets after the pancreatic, so we tend to ignore them. But they behave differently. I think initial evaluation for these tumors should be on the grounds of lung cancer. I think once you diagnose them, then you approach in a different way. And these tumors are ideally resected surgically and then hormone targeted as before the surgery. Most of them are predominantly ACTH secreting tumors. I think you target that, stabilize the patient. I think these patients present with severe hypokalemia, and that's the clue for that, and you correct that and address the issues. And more recently, mTOR inhibitors, everolimus, has shown to be quite effective in bronchopulmonary nets, and that can also be used. So there's a lot of options available. I think there are plenty of options. I think starting from somatostatin analogs, which were the first ones we used, and then mTOR inhibition recently with everolimus and temsirolimus, and anti-angiogenic therapy with sutimlimab and bevacizumab. And cytotoxic therapy, although it is being used less and less with a lot of options available, I think still remains an option. Telotristat, it's a hormone medication which inhibits enzyme tryptophan hydroxylase, so it's just blocking the enzyme which produces serotonin. And liver-directed therapy and PRRT with radionuclide scans, which I will let you know in detail next. So, somatostatin Elanox, I think this is the first one we used in carcinoid syndrome. I remember using this in patients with carcinoid crisis. And I think the problem initially was we used to use intramuscularly frequent doses 3 to 4 times a day. I think advent of analogs have made life easier, which can be given 3 to 6 weeks. I think initially we used to give just for symptom control, although we realized that it has actually delaying the progression of the disease. But there was no proper studies until only recently. I think in just a decade ago, we have evidence in terms of PROMIC study with octreotide and Clarinet study in lanreotide, which have actually shown significant prolonged progression-free symptoms and survival in these patients. So they have actually acts as anti-proliferative agents, and so I think so it's just not for the symptom control. So they are the appropriate first-line agents and still remain the first-line agent in all the NETs. It's just not the hormone secreting NETs which we are targeting with somatostatin analogs. Actually, non-hormone secreting tumors are also quite responsive, as shown in both the trials. So any NET tumors, the first choice still remains SSR. And the mTOR pathway, I think everolimus, which is used quite frequently in various oncology and renal transplant and bone marrow transplant situations, are quite used. I think there are a lot of studies going on this phase 3 trials, I think from RADIANT 1 to RADIANT 4, and still a lot of data is evolving. I think in conclusion, they have shown a significant response and progression-free survival in these situations. I think they are more useful in grade 2 pancreatic NETs, and they're also used who have a significant burden. In fact, they are used as first-line agent if the disease burden is more and they have got a very high mitotic index activity. They can be used as first line. And also more slow indolent cases which somatostatin is not helping, I think you can use mTOR inhibitors. They are fairly tolerated unlike other chemotherapy agents, and then can be used as a second choice. So this is peptide receptor radionuclide treatment. This actually what happens is you attach your peptide molecule to somatostatins, and these deliver the radionuclide substance into the cells. And they have shown a very good response, and the NETTER study has shown comparison of lithium glutatate plus SSA treatment with a high dose octreotide, and has shown marked progression-free survival and significant high response rate than high dose octreotide alone. This can be safely delivered and there's not much significant effects which are seen. I think there was only data in midgut NET, but I think recently we have got some data, and now it can be used as a second choice depending on the clinical condition and the suitability for the other options. Cytotoxic chemotherapy still has a role, as discussed, mainly for the poorly differentiated neck. I think they have a response similar to the lung cancer, small cell lung cancers. If you remember, they are very chemosensitive. Same thing, etoposide and platinum-based chemotherapies have a very good response in poorly differentiated neck, but unfortunately, like small cell lung cancers, will relapse in 1 year time. But you can have a repeat treatment. I think some are used in pancreatic NETs, but midgut NETs are probably no effective. I think, as I said, pancreatic NETs are more responsive. High-grade tumors respond more. Fast-growing tumors respond well to the treatment. And I think streptomycin therapy has been the main course of chemotherapy-based regimens in the last 2 decades. But I think recent studies have shown temozolomide-based therapy is probably the first choice, and has replaced streptozotocin-based therapies. There's a lot of radiological options. I think TACE and HAE, these are all target transarterial chemoembolization and hepatic artery embolization, radiofrequency ablation, radioembolization. They're all options available. Rocore lesional therapy. Patients who are not responding to somatostatin analogs or mTOR inhibitors, you have a very localized disease either in the liver or in the colon, and you want to target that. I think they are very useful. I think, remember, PET tumors actually have a better prognosis than any of the other chronic diseases like your COPD or any other thing. So these patients keep presenting to you with multiple relapses with various options. So these are the options we keep using for the same patient over a period of time. Terroristat, as I mentioned, is a novel way of treating PET NET tumors, in terms of it inhibits the enzyme tryptophan hydroxylase, which is very important for serotonin synthesis. So this is about NETs. I think I'll just come to more common topics which we endocrine in our practice, which we face. I think as an oncologist, I think hypercalcemia is a part and parcel of their treatment. I think use of bisphosphonate in metastatic disease on a regular basis has decreased the incidence of hypercalcemia, but tumor release of PTH is still the common cause, and we still see the incidences. I think initial treatment remains the same. Hydration. I think it's very important because these patients are quite dehydrated and sodium depleted. So they need a lot of fluids, which can range from 500 ml to 1000 ml per hour initially, at least for the first 24 hours. And of course the fluid replacement depends on the volume status of the patient. So once the patient is fluid depleted, we go for bisphosphonates. I think we used to use a lot of pamidronate. We used to give 60 milligrams or 90 milligrams, depends on the renal function. But I think most recently we've been using zoledronic acid, I think as the first line, which has replaced pamidronate. I think ibandronic acid has come again in these situations, especially patients who have severe or moderate renal impairment. This can be a good choice. I think patients who are refractory to this treatment, after 1 week, you can repeat the bisphosphonates, but you have to wait for 7 days. You can repeat the same dose. We used to use 60 milligram of pamidronate first and repeat with 90 milligrams. But I think you can use the same dose if your renal function is good. If the patient is resistant, then you can use denosumab, who are resistant, and I think it's been used as a first-line agent as well in some centers. Sometimes they can cause severe hypocalcemia, where you actually have to use the calcium supplementation to come over this crisis. As I said, calcium levels needs to be checked at 5 to 7 days, and then hypercalcemia, we can use denosumab or calcitonin. Corticosteroids have a role, especially in tumors who are secreting 125-dihydroxy vitamin D. So they has a role in that. Diuretics have no role in hypercalcemia, except for in situation where your fluid resuscitation is limited by volume overload. That's the only role. That's about hypercalcemia. Just going to the very vicious combination of diabetes and cancer. I think this has become I think as Dr. Srinivas was mentioning, the tumor burden in the society, the disease burden in the society with diabetes and cancer is going to increase, especially in our setups, and this is going to be a major problem, and we will be seeing more and more complex patients. So I think, as we know, I think the data is enough now to show that diabetes is independent risk factors for various cancers, especially we have got a good data for pancreas and colon, where the risk is 10 to 40 times more than other patients without diabetes. And diabetes prevalence is also increasing in cancer patients, estimated to 18%. So now we have known that in several studies that having diabetes hyperglycemia is associated with worse prognosis, increased mortality up to 40%, and associated risk of increased infections, post-chemotherapy, post-surgery, I think, as in any other routine complications. And neuropathy is a complex issue because of the chemotherapy and diabetic neuropathy, and erectile dysfunction is a concern. Hypoglycemia, I think, is a frequent problem because of the patients who are frail, whose appetite varies quite significantly. And a particular problem is, I think we all face in endocrine clinics, is the steroid use. I think these patients, they come with severe hypoglycemia when the patients are started on steroids, and they go home, you start on sulfonylureas or insulin, depending on this thing, and suddenly the steroid dose are tapered and patient go into hypoglycemia. It's a very difficult situation, and it needs a significant patient education to avoid this. And the other referral we are getting is, I think the nurse is calling us in the morning at 6 o'clock, the sugars are 200 and the patient is going for PET scan. So it's becoming more of a problem. So the nuclear physicists, they want the sugars should be less than 180. I think this should be managed properly before the patient actually comes from the PET scan, unless the patient is already in the hospital. So the sugars needs to be stabilized and then refer for a PET scanning. So so we have discussed about how your sugar impacts your cancer, and now how cancer and cancer-related treatment impacts your hyperglycemia. We talked about glucocorticoids, which acts in different ways, like increasing your appetite, decreasing your insulin secretion, and acts on several pathways. Insulin signaling pathway, as we know, is evolving rapidly as any other mechanism involved in oncology treatment, ranging from tyrosine kinase to IGF to GLUT4. So they have all a role, and all these are affected by the biological agents we are going to use in cancer. So we will be seeing more and more hyperglycemia with these kind of newer treatments, where your newer target-based chemotherapies and biological and immune therapies are going to replace your traditional cytotoxics. So we'll be seeing more related hyperglycemia in this. Androgen deprivation therapy used in prostate cancer is associated with hypercalcemia, but this is a chronic. These are chronic, unlike steroids where you see the glycemic excursion immediately. So somatostatin receptor analogs, targeted therapies like mTOR, AKT4 inhibitors, and all those have a hyperglycemia. Immune therapies, I briefly will talk about that, can cause hyperglycemia in a different way. Nutritional support, I think these patients are in different feeding regimes and variable oral intake, and you have to adjust your insulin regime according to the support. So bolus feeds needs only bolus insulin, continuous feeds needs continuous coverage. Continuous feeds can be covered by your intermediate acting insulin. You can use it for twice a day or once a day depending on the glycemic excursions. So you have to quite up to date with the patient's health, right? So glycemic targets, this is a very difficult to give as single glycemic targets because these patients are quite complex patients varying from mild glycemic excursion to significant glycemia. Again, it all depends on the patient has type 1, type 2, stage of the cancer and how the patient condition is. So I think guidelines in management of glycemia and cancer has not evolved. I think it's probably better because it's all up to the individual patient you are saying at that time, it decides your management. So, but these are just guidelines I have just shown you. I think so it's always best to avoid symptoms. Main thing would be you avoid your symptoms in terms of hypoglycemia, hyperglycemia or ketosis. I think if the patient has a good prognosis like chronic metastatic breast disease and colon cancer who have a very long survival, I think you can stick to your HbA1c target of 7.5. So that's no problem. And the other extreme patient who is terminally ill, who is almost have got hours, I think that's also fairly reasonable. I think we withhold a lot of treatment and minimize glycemic checks in these patients. And the problem comes into the patient who has prognosis from months. I think in these situations, how you manage these patients is again depends on how significant is the glycemia and the treatment patient is receiving. So usually I think the patients are on insulin, try to continue the insulin, but prefer intermediate acting insulins like isophane based protamine insulins. I think that will give us less chance of hypoglycemia and also will prevent excursions of the glucose because these will have intermediate acting, as we know, has a peak. Or preferably you can use just a basal insulin. But make sure insulin deficient patients, type 1 diabetes, you have to continue the insulin until very end of this thing because it will be quite difficult to know whether the symptoms are due to the cancer itself or due to the treatment or to the glycemia. So steroid, as I mentioned, I think for the steroids, I think some clinicians tend to use sulfonylureas. I think ideal choice would be short-acting insulin or a mixed insulin. So I think it's a brief discussion about, I think metformin because it has shown benefit in a recent study, in one of the studies has shown in improvement in mortality in stage 4 small cell lung cancers. So actually metformin can be used, but again you have to be cautious in renal and hepatic impairment. And sometimes patients with GI cancers or the chemotherapy which is affecting your gut, it will be difficult to assess whether it's metformin related or chemo related toxicity. Sulfonylureas can be considered and metaglenides, repaglinide, they can also be used. And then gliptins can be an option so that they will not cause hypoglycemia, but they are very, as we know, is moderately effective in your hyperglycemia, especially in acute situations. As I said, intermediate and long-acting insulin in terminal stages is better. So I think the main thing in here is a targeted diabetes education program, including diabetes clinicians, dietitians, is very important because it's a very complex situation. There's no right or wrong way. So it's up to the individual patient. We have to monitor our treatment and encouraging the patients to go for self-monitoring of blood glucose and adjusting their insulin is a very key. Lifestyle changes are equally important to both the patients of cancer and diabetes as a risk factor mitigation. And then I think evidence shows that we should not change clinical practice in use of anti-diabetic agents, just the fear of cancer being induced by anti-diabetic agents like we discussed, dapagliflozin or pioglitazone causing bladder cancers, and incretin mimetics implicated in pancreatic cancer, although we don't have much evidence. So that should not deter us to use any of these agents in cancer patients. At this time of evidence, I think we should use all these agents as appropriate in cancer settings. And in fact, we have evidence now there's a lower risk of cancer, especially with metformin and pioglitazone as well. So lastly, I think I'll just conclude by discussing about immune-mediated endocrinopathy. I think there's a revolution in oncology treatment with use of immune mediators. These are called immune checkpoint mediators, where they actually enable your immune system to uncover the hidden tumors which are hiding from our own immune system. So just unblock that and allows our immune system to target the tumor cells. So they are mainly CTLA-4 inhibitors, ipilimumab, and PD-1 inhibitors, which is nivolumab. I think these are used more and more. I think they are initially used with malignant melanoma, but they are used in various cancers now. I think they trigger various number of autoimmune endocrinology side effects. I think these range from hypophysitis, primary adrenal insufficiency, autoimmune thyroid diseases. I mean, thyroid diseases are quite variable. They can range from picture like your subacute thyroiditis, where you have a phase of thyrotoxicosis followed by hypothyroidism, and a pure Graves' disease, incidence of Graves' disease. Because remember, these are attacking your molecular basis and your antibody promotion. So, and the incidence of type 1 diabetes is also increasing because of these mediators, and in a recent data, there's a 3% increase of type 1 diabetes in patients receiving nivolumab. So the treatment, your diabetes management completely changes compared to other hyperglycemia, which are. So in these situations, it's difficult to recognize the symptoms because the patient is already on chemotherapy, cancer-related symptoms. So you might tend to ignore the symptoms related to this in terms of lethargy, tiredness, drowsiness, and all those things. So I think you have to be quite alert to recognize these symptoms and arrange appropriate investigations. I think this is just one of the things. So actually, patients using these agents, you have to be quite upfront. I think you have to have a basal pituitary profile in all these patients, along with a thyroid profile and a gonadal profile, and also followed by a monthly pituitary profile and a monthly thyroid profile, because these can change very, very frequently and without any warnings. So I think the patient is symptomatic and you have a low cortisol, you initiate cortisol replacement, and if the patient is hypothyroid and you have got a low TSH and low FT4, remember we are talking about secondary hypothyroidism, you replace, and estrogen and testosterone replacement according to the patient's situation. So you have to be quite careful. Evaluation, I think our usual markers are quite helpful here to differentiate what kind of thyroid problems the patient is having. So anti-TPO, anti-globulin, thyroid globulin, and TSI, which we use in Graves' disease, is quite helpful here if the patient is thyrotoxic. Sometimes you might not be use radionuclide scan because the patient is already on radionuclide therapy. So doing a radionuclide scan is not much helpful, uptake scan. So in that situations, the thyroid antibody, TSI, TRAB antibodies we call, I think they're quite helpful in your diagnosis. And GAD and IL-2 antibody to diagnose your type 1 diabetes related to these treatments is very important. MRI pituitary shows thickening of the stalk, which is quite peculiar for these agents, which is seen even before you can see the clinical or biochemical picture. So pituitary functions, just to be aware that any oncology patient we are seeing having these targeted therapies, you have to go for you have a very low threshold to request these, and most of the toxicity is permanent, unfortunately. Even after the treatment is stopped, they have a permanent damage, and they need lifelong treatment. Thank you very much for your patience. Thank you.
Under the scenario now.
What about treatment?
IVF injection is possible. Well, in postmenopausal women, for any treatment, we need an egg. So if she's not making eggs, then usually what we do is, in these women, we find the LH is high, FSH is high. That's how we diagnose that they're postmenopausal. The AMH is very low. In these women, if there are no eggs produced at all, we use donor eggs.
Preserved the eggs in the premenopause.
Oh,
Maybe she
okay.
meant that way.
Oh, you mean if she's preserved her embryos?
Yes.
Absolutely, ma'am. Success rates are very, very high because we just have to prepare the endometrium. We can give hormonal supplementation and postmenopausal women wanting it is not very common, but we have women with premature ovarian failure who come. And if they have frozen, like they have one child from IVF and they have frozen embryos, and the second time when they have premature ovarian failure, the success rate is very, very high, ma'am. We can do it. We can just prepare the lining with estrogens and transfer it. And postmenopausal women, as for them, if they come for the first time, we usually advise for donor eggs.
Yeah, is there any role of myoinositol in PCOS to regularize the menstrual cycles? Apart from the hormonal things.
Of late, there are some trials because, as I said, the D-myoinositol pathway is very important pathway of insulin resistance. But they are not randomized controlled trials and the efficacy is not proven. So routinely, we are still not recommending to patients.
If they recommend also, how much period we can see how much the results we can, at least how much period we can give for the patients?
I have actually not used it, so I can't comment.
Okay.
And last question. Yeah, 15-year girl coming with functional amenorrhea like anorexia nervosa. Secondary amenorrhea, since last 6 months she don't have any cycles, and FSH LH are like normal 5 to 6, and estradiol are also normal. So we want your experience on anorexia nervosa. Will you? Yes.
I had one really classic patient of anorexia nervosa, and usually FSH LH levels will be low normal, and estrogen also is low in these patients. And if the patient is given we usually give the oral contraceptive pills. The HRT is the usual treatment till the patient recovers from the psychiatric illness. Proper psychiatric counseling and treatment is very important, and usually these girls do well. It all depends upon the patient's thing. But that patient which I had responded very well, and fortunately she had a good psychiatrist to meet, and she was out of the disease by 2 years. And without any hormonal treatment, she is menstruating regularly now. So it all depends upon the counseling given and proper support, which is very important.
Yeah, to regularize the cycle, it will take 1 to 2 years.
Yeah, at least, yeah.
Thank you so much.
In that, my patient, it took at least 1 year.
It depends how the counseling, how she has came out of anorexia nervosa.
And also how duration of the disease also. If it's very long standing, if she's not been treated for years together, then the possibility of recovering would be lesser. That's there definitely. So if you intervene early, because she was just 16 and a half years when I said, so because it was a short duration of history, she responded very well. It's a long duration, say more than 3 to 5 years, probably the response rate would not be as much as I've told. Yeah.
Thank you.
Can I ask Dr. Sridevi also about metformin in pregnancy?
Yes. Yeah, metformin in pregnancy, actually, as I said, we have trials, the MIG trial and other trials. We actually, the prevalence rate in this trial when compared to insulin, it was done in almost 750 odd women with gestational diabetes who were refusing insulin and all. So basically, the use of metformin along with insulin has been shown to decrease the weight gain in pregnancy and also decrease the insulin requirements. That is confirmed. But most of these trials have shown that there is increased risk of preterm deliveries, and in the particular trial what I was mentioning, almost 47% required insulin again. So if you are writing metformin, if the patient is not willing for insulin only, we usually write, because it is not approved by the DCGI and you might face even legal consequences if it is challenged in a court. So you need to tell to the patient that it is not approved, and you might need insulin, you need monitoring, and there is an increased risk of preterm birth. So if the patient is willing for all this, then you write metformin. Otherwise, you and patient both may land up in a soup later in this. Okay.
I'd like to add in this context. Indian government has approved metformin in 2017 and have been using it since past 1 year. And in a motivated patient who is on strict MNT, metformin works at least till almost 7 to 8 months of pregnancy. Beyond that, usually insulin requirements are there because of the heightened insulin resistance which is there.
And both the ADA and British, everybody has approved metformin.
Yeah, now it is. Not in the first trimester.
Not in the first trimester.
And it has reduced the usage of insulin by almost 80% in the UK. So you can understand the value of metformin as a gestational diet. It's not pre-gestational.
I think that's the Ministry of Health in the recent one, that is 2018, March 2018, they have added that, and this is second and third trimesters. And the other issue is that the MIG trial and all that, on the follow-up of infants, we thought that there was going to be improvement in their fat and this thing, but it is actually not so. It's not so. That's not seen in the recent data that is analyzed. So I think we still need to look out, and insulin still remains a good option, and all the metformin may be used in appropriate patients.
I think possibly that whatever transient benefits we have seen in the children who are born to the mothers who used in metformin during, probably transient. They expected it to be there when they grow up also, low visceral fat and more of subcutaneous fat in the children who are born to the mothers who used metformin. Probably that is not so.
No more questions. On behalf of Dr. Neelavini and I, we thank the IDEA Clinics and all the team for giving me this opportunity to chair this session. Thank you.
I request Dr. Rakesh Sai to please hand over mementos to the chair.